Now we will start our yeah. So we are going to start our simulation program. Initially, Dr. Munish has taken class on basics of ventilation. Now we will continue on the different modes of the ventilation as well as scalars and other physiological basis, as well as how we can deal with the ventilation in different type of the diseases like ARDS, normal ventilation, or in COPD ventilation. But before that, still there is a lot of basics in the ventilation. So we will start from the basic. What is ventilation? Ventilation means there is respiration is different. Yeah. So ventilation means just a removal of the air which is high content of the CO2 with O2 rich air. This is the basis of the ventilation. And normally we do it regularly without knowingly or unknowingly. We are doing constantly from the time of our birth till the death. We constantly do ventilation. Okay, so this is our regular practice, but we don't know what we are doing regularly. That is a very important part of our life, but we don't care about our ventilation, our respiration, because this is automated process. Automatically it has been provided by the nature to us. Without any efforts, we do our respiration or ventilation constantly. But what is the meaning of ventilation? Ventilation means removal of the our air inside the lung, which has high content of the CO2, or removal of the CO2 from the lungs from external air, which is high or rich in the oxygen. Okay, so basically, whatever kind of respiration or ventilation we are doing, hello.
55 bicycle TLC, no, WBC to 2.5. They led to 55,000. They led to grow like 6.
Is someone asking any question? Hello. Okay, so please mute your audio, otherwise it is creating unnecessary uh, voice disturbance during the class. So ventilation, as I have discussed, this is the removal of the CO2 from the lung with oxygen enriched air from outside environment. How we can do it? We can do it with a normal respiration, which is normal ventilation, or normal respiration, which is negative pressure respiration or negative pressure ventilation. So what does it mean? It means it means we have to create negative pressure inside our thoracic cavity. Inside our thoracic cavity, we have to create negative pressure. And how does it happen? It happens by expansion of our chest wall externally and downward contraction of diaphragm. Okay. So inside, this is the entirely thoracic cavity is entirely a closed chamber where it is closed from the uh, glottis side and from periphery the air cannot leak out. So this is the closed chamber. So whenever there is closed chamber and expansion of walls will be there, and this downward contraction of diaphragm will be there will be the increase in the area of this cavity. So automatically there will be vacuum or suction pressure build up inside this cavity. So person can inhale easily in the lung through the our airways, ultimately to the alveoli. These smaller area are alveoli. Okay, so in alveoli pressure through negative pressure generation, this alveolar chambers will fill. Ultimately, after some time, when completion of inhalation, after the completion of the inhalation, patient or person will exhale the entire air outside. This is the commonly known as the negative pressure respiration or negative pressure ventilation. But in but in positive pressure ventilation, what does it mean? Now this mechanism, which has been taken care by our muscles, our diaphragm, our airway, is taken care by the ventilation. And how does it happen? It will happen by pressurized transfer of the air from ventilator to inside the lung. Okay, so suppose this is the ventilator, this is the lungs. Okay, so it will generate positive pressure, it will transfer inside the lung, and this is basically depends on how you are guiding the ventilator for your ventilation. Okay, so basically this generation of the positive pressure air inside the ventilator will transfer inside the lungs, and after particular time, which is after completion of the inhalation, exhalation automatically occurs. Okay, so this is completion of the respiratory cycle. What is the meaning of respiratory cycle? Inhalation plus exhalation, inhalation plus exhalation. So whenever we are doing our own ventilation or respiration in the form of negative pressure ventilation, we will take our inspiratory time actively. That means whatever air we are taking inside our lungs, this is active process. But whenever we are exhaling, this is passive process. Same thing is here in the positive pressure ventilation, where ventilator has to work actively during the inhalation part. That means transfer of air from ventilation to inside alveoli. This is the active part. And when exhalation start, it will occur automatically. So there is one is active process, that is inhalation. Another is passive process, that is exhalation. Okay. Now how we can calculate our respiratory cycle? Suppose someone is breathing per minute at the rate of 15 breath per minute. Okay, so that means he is taking 15 breath in 60 seconds. Okay, that means 60 by 15 is equal to 4 second is one respiratory cycle. Okay, what does it mean? It means patient is completing his just a minute, completing his inspiration plus expiration in 4 seconds. Okay, so this is one respiratory cycle. So he will complete 15 cycles in 60 seconds. So each cycle will take 4 seconds. In that particular part, we can take, or actively we can divide inspiration plus expiration according to the our need. What does it mean? It means we can we can give particular amount of time for the inspiration. Suppose out of 4 seconds, we can give 1 second for the inspiration, and that extra 3 seconds will be taken care by for the exhalation. Everybody clear? Hello? Is anyone listening?
Yes, it's clear, sir.
Yes. So do you have any question? Are you getting it? What am I telling you?
Yes, sir.
Hello? Hello?
It's clear, sir.
Okay. So with whom I am talking?
Nung Sangla, Dr. Nung Sangla.
From
Dimapur, Nagaland, sir.
Nagaland. Okay. Okay. So out of 4 seconds, we can give 1 second or 2 second or 3 second for the inspiration, which is active part, or whatever left time will be there, it will for exhalation. Okay. So we have to choose your inspiratory time very diligently, because whatever time we will allot for the inspiration, we are stealing it from the exhalation part. Okay, now suppose, just now suppose out from from 15 second to, it has been increased to 20 second, 20 breath per minute. Okay, what does it mean? Now person is taking 20 breath in 60 seconds. That means 60 by 20 is equal to 3 seconds. Okay, that means you have reduced your respiratory cycle from 4 seconds to 3 seconds. So if you are still allocating 1 second for the inspiration, so now you left 2 seconds for the exhalation. Okay, so you have reduced the exhalation time merely by increasing the respiratory rate. So this part I am telling you again and again, because entire ventilation is depend only on the I ratio, that it is known as the IE ratio. How much time we are giving for the inhalation and how much time we are giving for the exhalation. Suppose 4 second respiratory cycle, we are giving 2 seconds for the inspiration, automatically 2 seconds will left for the exhalation. So I ratio will be 1:1. Now, if we are giving 1 second for the inhalation, so now 3 seconds left for the exhalation. Now I ratio will be 1:3. We are giving more time for exhalation, we are giving less time for the inhalation. This concept is entirely responsible for the ARDS ventilation as well as the COPD ventilation. Okay, so just a second. Yes, so we have discussed what is ventilation. Ventilation is just merely removal of the air which is which has high content of the CO2 with O2 enriched air, that is ventilation. Either it can be normal, or that means negative pressure ventilation, or through ventilator, that is positive pressure ventilation. So now we are coming to ventilator. Suppose this is ventilator. So can you just start this ventilator to any, and how it will work? So before starting of the ventilator, person has to be intubated. Intubated means we have to enter one tube inside the airway that will be connected to the ventilator. Then we can utilize our ventilator for the invasive ventilation. I am not talking about non-invasive, I am talking about the invasive ventilation. So once you will intubate the patient, you have to connect with the ventilator, then you have to give proper instructions to the ventilator, because ventilator is just a machine that is completely moron, that doesn't know how to behave, how to work, how to deliver tidal volume. So you have to give clear cut instruction to the ventilator, then only ventilator can work. Okay, so how it will work? So basically now you have to give instructions to the ventilator on the basis of respiratory rate, tidal volume, flow, and pressure, and as well as cycling. Okay, so what is cycling? Cycling, first of all, we will understand what is cycling. Cycling means one cycle is completion of inspiration and completion of expiration. This is the complete one cycle. Okay, so or sorry, cycling means after inspiration exhalation will occur, then again inhalation will occur, then again exhalation will occur. So ventilator doesn't know how to do that, so we have to tell them, so we have to tell him exactly how you will behave. That is cycling. That is depend on either time cycle, volume cycle, or flow cycle. Okay, so what is the meaning of time cycle? Meaning of time cycle means we will instruct the ventilator that you will take 1 second for the inhalation. You will take 1 second for the inhalation. After that, automatically exhalation will start. This is time cycle. What is volume cycle? Volume cycle means we will instruct the ventilator that you have to deliver volume of 500 or 400 or whatever amount you have fixed to the lung, then you can allow for the exhalation. So time cycle was dependent on the time you will instruct clearly to the ventilator that you have to give inhalation time for that particular time, maybe 1 second, maybe 1.2 second or 2 seconds. After that, automatically exhalation will start. In volume cycle, you are giving instruction to the ventilator that particular amount of the volumes, it may be 400, 300, 500, whatever, you have to choose it. You will instruct ventilator. Then after delivery of that particular amount of the volume to the lungs, to the alveoli, automatically ventilation will shift towards the exhalation. Third is flow cycle. That is pressure support ventilation. Okay, that is we follow in the weaning mode. What does it mean? It means after particular remaining flow. Suppose starting flow was 100 liter per minute. We will instruct ventilator that 25% of your peak flow, that is 100 liter per minute, was peak flow. Mhm. Just hold on, please. Can you see? Yes, I think I have lost my screen share. So just give me 2 minutes. Okay. Is it okay now?
Yes.
Okay. Okay. So so where we were. So that was flow cycle. Flow cycle means so flow cycle means initially suppose flow was 100 liter per minute, which is peak flow of the ventilator. Now we will instruct ventilator that cycling will be at the 25%. That means 25% remaining flow. That means initial peak flow was 100 liter per minute. It will gradually going down, and when it will reach at the 25 liter per minute, automatically inhalation will stop and exhalation will start. Okay. Okay. So this is the flow cycling. So what we have discussed, we have discussed first time cycle, then volume cycle, then flow cycle. So this is the first instruction to the ventilator, that you should behave in this manner. You have to cycle in this manner. You have to inhale or exhale in this particular manner, either in the time cycle or particular time of the inhalation you have to exhale, or after delivering of the particular amount of the volume you have to exhale, or after remaining peak flow of the particular amount, maybe 25% of the peak flow or 40% of the peak flow or 50% of the peak flow, you have to exhale. This is our first instruction to the ventilator. This instruction is based on, this instruction is now based on the your mode of ventilator. Okay, so your mode of ventilator can be VCV, PCV, or pressure support ventilation, which is weaning mode. Okay, so volume control, that means we are controlling the volume. So this is volume cycling. Pressure control, we are controlling the pressure with cycling of the time. So this is time cycle. Pressure support, we are, this is weaning mode, that is flow cycle. Okay, so this is flow cycle. So now we are coming one by one. What is the meaning of the volume control? What is the meaning of pressure control? Okay, so first we have cleared what is the meaning of the cycling. Now there are three important things inside the ventilator. Whenever we are ventilating any patient, we have to see for volume, then flow, then pressure. Okay, so we have to see volume, which is tidal volume, flow in the liter per minute, or pressure. So there are particularly, now we can divide the ventilation in the VCV or PCV. Okay, so three things are there: volume, pressure, and flow. So first of all, we will talk about the volume. In volume control ventilation, as it mentioned, volume control, that means we are giving controlled volume. That means we can control the amount of volume which will be delivered to the lungs. What does it mean? Either we can control it on 300 or 400 or 420, 450, 500, whatever. This is depends on our choice according to the pathology and physiology of any particular lung. Okay, so if we are controlling the volume, two things will be variable. Okay, so what is fixed? It, what is fixed in volume control? That is volume. What is variable in volume control? only two things left, that is pressure and flow. Because suppose there is balloon which is not very stiff, and you are inflating this balloon with 500 ml of the air. What will happen? Pressure can be different. If it is very hard balloon, pressure will increase inside that balloon cavity. And according to his stiffness, you the according to stiffness, you have to give volume in particular time. Okay, just a minute. So what is fixed in volume control? That is volume. Second is flow. Why flow is fixed? Because you have to give particular amount of volume in particular amount of the time. Suppose you have to give 500 ml of tidal volume in 1 second. Then only has to be fixed. Then only you can give complete amount of tidal volume in that particular time. So in volume control, volume is fixed, flow is fixed. But according to the physiology and pathology of the lung, the pressure inside that particular lung will be different. So that's why there you cannot control pressure inside lungs with volume control unless until you are controlling your volume and flow particularly. Then you can reduce or increase the pressure inside the lungs. Okay, because the stiffness is different in each and every lung. So that's why sometime in the normal lung, even 500 ml of the tidal volume will not increase plateau pressure more than 20 or 25. But 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 uh, in ARDS patient where lung is extremely stiff, little bit amount of the tidal volume, it may be 250 or 300, can increase plateau pressure exponentially. So what is the meaning of the pressure? Pressures are, there are two types of the pressure. One is peak pressure, another is plateau pressure. So what is peak pressure? Peak pressure is pressure inside the bronchus, main airway or large airway. Okay, and this is the lung. So this is the lung, this is main airway, then right and left bronchus, then terminal bronchus, and finally alveoli. This is for complete formation of the lung. So peak pressure is pressure inside this area of the main airway, and plateau pressure is basically pressure of the alveoli. Okay, so if plateau pressure is very high, that means your lung or alveoli are very stiff. If peak pressures are very high, it means there is sparse or very high resistance inside the main airway. It may be due to the asthma, it may be due to the COPD. But if your plateau pressures are very high, it means patient is going into the stiff lung. It may be due to ARDS, cardiogenic pulmonary edema, or non-cardiogenic pulmonary edema. Cardiogenic pulmonary edema means flooded alveoli or flooded lungs, or non-cardiogenic pulmonary edema, it may be ARDS, where alveoli are very stiff, they cannot expand further. That's why pressure inside these alveoli are very high. Okay. So we have discussed about the volume control ventilation, what is fixed volume and flow. What is variable? That is pressure. That is cycling. Cycling is volume cycling and time cycling. Now we are coming to pressure control ventilation. What is pressure control? As we can see by its name, we are controlling the pressure. So what is fixed? That is pressure. What is variable? That is flow and volume. Okay, so now we have to understand what is pressure control. Pressure control is suppose there is one is normal lung, another is ARDS lung. Okay, in normal lung, compliance is very high, near about 50. In ARDS, compliance is 20. So what is compliance? Compliance means expandability of the alveoli or expandability of the lungs. How much that particular lung can allow air inside the alveoli, how much it can expand, how much it can accommodate air, that is compliance. So if compliance is if compliance is very high, that means lungs are towards the normalcy. Extremely high compliance can be there, especially in the COPD, especially emphysematous lung, which is also not a good thing. But we are not going into that details. We are just discussing the compliance. Compliance, very low compliance means that is a stiff lung. Lungs cannot be expand or lower expandability of the lung. Normal compliance or high compliance means normal expandability of the lungs. So suppose we have set pressure of 30. Okay. So it is possible, it may be possible that normal lung can accommodate volume of 500 ml. Okay, 500 ml with set pressure of the 30, because we have fixed the pressure in pressure control at the level of the 30 mm of Hg. With this set pressure, ventilator can give or deliver 500 ml of the tidal volume to normal lung. But it is not possible to ARDS lung, which has very low expandability due to very low compliance. So in that scenario, it may be possible that it can accommodate hardly 250 or 300 ml of the tidal volume. So this is variable. Your pressure is sorry, pressure is fixed and your volume is variable. So because volume is variable, flow is also variable, because in 500 ml it may be possible that initial flow is 100 ml per hour, which is reducing gradually and going towards the 20 ml or 10 ml per hour. But in this particular settings, it may be possible the initial flow is only 50 liter per not hour, 50 liter per minute, and gradually so it may decrease up to the 30 or 20 liter per minute. So this is the basic understanding of the volume control and pressure control. So what we have discussed: ventilation, then negative pressure versus positive pressure ventilation, then respiratory cycle, then cycling, then modes. So what is different modes are there? There are volume control or pressure control mode. We are not discussing about the pressure support ventilation at present, because this is typical weaning mode, and we will discuss it at the end of the our first these basics of ventilation lectures. Okay, we will discuss it in the COPD on ARDS ventilation. So volume control mode means fixed volume with variable flow and variable pressure. In pressure control, pressure is fixed, but flow and volume will be variable. Okay, so one thing is, two things are fixed in the volume, which is volume and flow. These two things are fixed, pressure is variable. But in opposite to pressure control, pressure is fixed, but volume and flow is variable in the PCV. So when pressure is fixed, volume and flow will be variable in the pressure controls ventilation. When pressure is variable, then in volume control ventilation, volume and flow will be fixed. Any question? Any question? Everyone is understanding it? Is anyone listening this lecture?
Yes, yes, we are listening.
So
Sir, we
are
are
you getting
listening.
whatever am I? So are you getting whatever am I
Yes.
telling you?
Yes, sir. It's very clear, sir.
Okay. So do you have any question?
No, sir. No, sir.
Okay. So now we will talk about what is assist control versus control mode. Okay. In either VCV or PCV, we can utilize this terminology of the assist control or control mode. So what is control mode? So in control mode of ventilation, ventilator is taking full control. What does it mean? You have instruct the ventilator that suppose you have started with the volume control mode. So you have given complete instruction to the ventilator that you have to give 500 ml of the tidal volume, flow of 60 liter per minute, okay, with respiratory rate of 20 breath per minute. This is the instruction given by you to the ventilator. So what will happen? Now ventilator will give complete 500 ml of the tidal volume in each breath, which is at the rate of 20 breath per minute. So in this particular method of the control mode, your lungs or person is not initiating the breath. this is completely volume cycle. After complete delivery of the 500 ml, automatically exhalation will start, then again automatically inhalation will start. Okay, so this is the control mode where patient or person is not initiating at all. This is under the control of the ventilator 100%. After every 3 seconds, automatically the ventilator will deliver a breath with 500 ml of volume to the patient or to the person. This is control mode. So basically over here, suppose this is I'm drawing another diagram. This is, suppose this is alveolar pressure. Here again alveolar pressure is constantly positive. Okay, alveolar pressure is constantly positive. It is not going to the negative pressure. But suppose I have set it to the assist control mode. Assist control with the volume control ventilation. Now we are instructing ventilator with 500 ml, 20 rate and 60 flow. What will happen? First of all, person or any patient on which we have started this assist control volume control ventilation, he has to initiate breath, which we call triggering, with the negative pressure. He will generate negative pressure inside the alveoli. This negative pressure is known as the trigger. After this triggering, ventilator will deliver 500 ml. Okay. In control mode, patient or person not need to trigger. Without triggering from the patient, or person, ventilator will deliver tidal volume. But in assist control, person or patient has to trigger first, then ventilator will deliver. Okay. Why it is necessary, we will discuss in the further classes. What is the advantage of the assist control over the control mode? So this is the basic difference. What is difference between the assist control, that is triggering, with control mode, where no trigger required, only after particular delivery of the volume and after particular time, automatically it will deliver another breath to the patient. This is control mode, and when patient will trigger, it is converted into the assist control. Is it okay? Now, lastly, we have to discuss about the trigger. What is trigger? Trigger means initiation of any process. It may be trigger of the revolver, trigger of the sneezing, trigger for any particular reaction, or triggering of any particular event. Okay, so that particular action just before that particular reaction is known as the trigger. Okay, in this pattern of the ventilator, triggers are two types. One is pressure trigger, another is flow trigger. Okay, so there are two types of the triggers. One is pressure, another is flow. Okay, what is the difference? Pressure trigger, suppose this is the line, this is volume time scalar. We will discuss in detail about the scalars in next class. Okay, so this is wall inhalation of the 500 ml, then exhalation, then inhalation, then exhalation, exhalation. Okay, so this green part is inhalation part, and this orange part is exhalation part. This particular starting point of the inhalation, patient has to create negative pressure. Okay, patient has to create negative pressure. Okay, this is zero pressure, patient has to create negative pressure. How he will generate negative pressure? Again, by simple basics, as we have discussed, by negative pressure ventilation, patient has to create negative pressure inside the thoracic cavity by expansion of the thoracic cavity outside and downward distance of the diaphragm. So ultimately it will create vacuum inside the lungs and thoracic cavity, and this ventilator will detect that now this particular amount of pressure has been generated inside the thoracic cavity. So now you have instruct him to deliver the tidal volume after generation of this particular pressure. It may be -2, it may be -3 or -5. Okay, so negative pressure is always negative, lower side. So more minus means more pressure generation. That means he has to generate more negative pressure. He has to generate more negative power. So he has to uh, uh, work harder in the generation of the -5 mm of Hg rather than -2 of mm of Hg. So once you have set pressure trigger of the -2, then patient has to trigger up to the level of the -2 mm of Hg, then only this ventilator will deliver next breath. Okay, again when he will deliver, he will create or generate -2 mm of Hg of the negative pressure, then again it will deliver another tidal volume of the 500 ml. Now suppose I have set to the flow trigger. Okay, I have set it to the flow trigger. What does it mean? Now I am ordering or instructing ventilator that you have to deliver that particular amount of the tidal volume when there is generation of typical maybe 3 liter, 4 liter or 2 liter flow by the patient. What does it mean? There is ventilator, this is tubing, this is inhalation tube, this is exhalation tube, this is connected with the patient. So when patient is not breathing, there is particular flow is going on between this tubing, which is known as the biased flow. Generally it is near about 6 liter per minute of the bias flow is constantly going inside this circuit. Okay, so when we have set flow trigger, that means we are instructing this ventilator that whenever you will realize or whenever you will sense that there is particular fall of maybe 3 liter of flow or 2 liter of whatever we have set, maybe if we have set 2 liter of flow trigger, that means patient will generate negative pressure. He will suck some air. That air will come out from this bias flow inside the lung, and there will be drop of the 2 liter out of the 6 liter. So there will be only 4 liter of the bias flow inside this circuit. So ventilator will automatically sense that there is drop of 2 liter of flow from this bias flow. So he will sense now I have to deliver tidal volume to patient. So this is flow trigger. So this is flow trigger. First was pressure trigger, generation of the negative pressure inside the thoracic cavity from -1 to -5 or -6, whatever. Okay, so more negative, more generation of the negative pressure, more work of breathing to the patient. Flow is in the positive side, upper side. Pressure trigger on the lower side. Flow trigger, that means out of that bias flow, patient is stealing that particular amount of the flow which we have instructed that when patient will generate that amount of the flow, it will reduce from the bias flow and it will be sensed by the ventilator and it will deliver flow to the tidal volume to the patient. So this is the basics of the our ventilator strategies. And before starting off our next class on the topic of scalars, okay, and loops. So I am just concluding this class with 3 diagrams of the scalars. Then on next class we will discuss further related with the scalars and simulation of these scalars on the our simulator. Okay, so basically there are 3. This is time, sorry, this is volume, this is volume time scalar, this is volume, and this x-axis is time and this y-axis is volume. This is volume time scalar. We will discuss in detail about these scalar in our next class. Second is flow time scalar. This is flow time. Again, this is time. This is flow. This is negative flow. This is positive flow. Okay. Thirdly is pressure time scalar. This is the peak pressure, then plateau pressure, then peak pressure, then plateau pressure. So this is peak pressure, this is plateau pressure. Okay, again, this is time, this is pressure. So x-axis is time, this is y-axis. Okay, so in our next class, we will discuss about all these 3 scalars, importance of these scalars, and how we interpret during the ventilation only with the scalars, what is the problem inside our ventilation. Okay, any question? Any question till now?
No, doctor.
Okay then. Okay then. This is conclusion of our I am concluding this class over here. On next class we will discuss from this point how to interpret our scalars. Okay. Okay, good day.
Thank you.
Thank you, sir.
Yeah, most welcome.
Okay, sir. Thank you.